flag.
Oh my God.
We say the Pledge of Allegiance before. I have no idea how long it's going to be, so keep wave at me if I'm going to. It's an hour. Yeah.
How many do you have counted? I got 65.
Here, right? I haven't counted the in room yet. I've
I hope
got
Michael
1,
feels
2,
better.
3, 4,
It's
5,
just such a
7 on
an
Zoom.
issue.
7 on Zoom.
Your stomach. Well, I'm not so on,
7.
so it shouldn't be too.
Just
bad.
7 so far, but people are still
Oh,
coming.
you need questions?
People just in the Zoom room.
Good morning. I'm Christian Esteban. I'm the president of the Coronado Roundtable. Welcome, everybody, to another program, a very exciting program this morning. So I'm happy so many of you can come today on this somewhat tropical Coronado morning. Yes, well, at least we're not in New Orleans where it's 100
Cool.
degrees. Some places.
The water temperature in Florida hit 100 degrees.
100 degrees in New Orleans. may as well be
15.
But anyway, Lyman Green is here providing coffee for us. Thank you, Lyman. If you're all comfortably seated, if I can ask you to stand for the Pledge of Allegiance. I
Pledge allegiance to the flag of the United States of America, to the republic for which it stands, one nation, under God, justice, and justice for all. Okay. I forgot the words.
No, play ball.
As you may know, our programs are being recorded, this one included on Zoom. So we thank Nicholas Burmeister this morning from the library staff for that. So it will be, should be available later, recorded as it is later today on the YouTube. But for now, for those of you at home, if you can turn off your camera. And also in the question and answer period, that will be available in the chat box for those at home. For those of you in the back, please, if you can't hear the speaker, please raise your hand and we can try to control the volume. Our next program after this one will be Friday, August 25th, here in the Win Room at 10 o'clock. And we will have Dave Landon from the Roundtable Board speaking about the history of North Island Naval Air Station, and before that, part of the Army's service as well. So that's August 25th, 10 o'clock, to the history of North Island. Following that, in September 22nd, I'll be speaking on the topic of genealogy and DNA and the ancestral voyages that DNA can discover. So that's September 22nd. But today, our speaker is Dr. Stephen Phillips. And we have our very own past president, Kurt Henry, who will provide that introduction. Kurt?
Thank you very much. It gives me a great deal of pleasure to introduce Dr. Stephen Phillips. And as I begin to learn more and more about him, I begin to find out that as the extremely important care of cardiac patients developed over the last 50 years, that he's been right next to it the whole way. So to be official, he's a certified heart transplant surgeon that is certified by the United Network for Organ Sharing. That is not necessarily a local organization. It has a broad reach for hearts that are imported and transplanted. He's a graduate of Hobart College and Tufts Medical School. He co-founded what became the Iowa Heart Center in Des Moines, Iowa. He retired from clinical practice in 1999 and took a senior position at the National Library of Medicine, part of the National Institute of Health in Bethesda, Maryland. In 1974, he pioneered techniques for emergency coronary bypass surgery for evolving heart attacks. And along the way, he also designed a surgical procedure for infants with a certain type of a congenital heart disease with reduced mortality from 30% to almost zero. Along the way, he served 2 tours in Vietnam in 1968 to 1970, remained a reservist and retired as a lieutenant colonel in 1993. This is a military town. That's worthy of note. Dr. Phillips.
Army guy.
Okay, I served in the Army. Dr. Phillips has approximately 140 peer-reviewed medical publications and has been granted 6 patents. Importantly, he was a medical advisor to Dr. Michael DeBakey of Houston, Texas, a world-famous cardiovascular surgeon who pioneered artificial hearts and bypass surgery and developed a host of devices to help heart patients. He married Susan, who's sitting on the front row right next to him with the pink sweater. They have 5 children, 9 grandchildren, and they live in Coronado. Off the record and out of the journal, Dr. Phillips confided in me that on Wednesday he turned 83 years old. Dr. Phillips.
Well, thank you, Kurt. I just want to mention, and well, thanks for the roundtable for inviting me and for all of you to come. I see a lot of friendly faces and I hope they'll still be friendly when I finish. But I turned 83 on Wednesday and that was no big deal. The special thing that happened to me on Wednesday was that I got Wordle and won. I really did. I put in heart. Well, the word was heart, H-E-A-R-T. Interesting. Well, heart transplants and other fun things that I did. I'm not sure a lot of people would consider them fun, but we had fun. The patients, well, anyway. I divided up. Well, it's coming up here, but it's not coming up on the screen. Well, while we're doing this, I just must say that we moved here almost 6 years ago. And this is the first time in 6 years I had to put on clothes. I frantically was throwing things right and left. This doesn't fit any longer. This has no buttons. So since we can't get the slides to work, we can just have a coffee break.
It'll be up in just a second.
Okay. Well, while we're doing this,
There we go.
okay. Anyway. Well, let me try it this way.
I think you're hitting it wrong, but I think hit that one.
Oh, okay. Didn't happen in the operating room, but I broke my my comments up into three areas. One, the first one is about heart attacks, and what they are, and how we treat them, and how we used to treat them. The second is about heart transplants. And if you read the little banner, believe me, that never really happened. But I did have to show it. And on the last part of my comments, I want to share with you information about the artificial heart support pumps, and some of my research. Now, I'm going to go a little out of order because I do have some show and tell things that I want to pass out to you all so that you could look at them and don't use them. Don't use them. But these are real. This is an artificial heart. I'll start with Mr. Kelly. And that's actually implantable if we sterilized it and cleaned it up and found the willing patient. This is a DeBakey pump, and I'll talk more about it. It works very much more differently. And we'll just pass it around the room so you can all look at it while I'm making my comments.
Transplanted, I mean, that gets put in.
Yeah, there have been about 3,000 of those.
I could use this right now.
Well, if you want to stay after the conversation. Now, I have a couple of models that I suppose won't show up that I was going to do a live demo on, but I think we'll skip that. And I'll pass this around as well. This is something that has not been used clinically, but it's an interesting pump. It's a magnetohydrodynamic pump. So let me do that. And we could play with those while I go ahead and make my comments. What is a heart attack? Well, we all know the terminology heart attack, but what is it really? We all have friends and family, and perhaps even ourselves have had the big one. But heart attack is basically a mechanical issue. You end up with a block in a coronary artery, the artery that supplies blood, oxygen, and nutrition to the heart muscle. And the area that the artery supplies becomes ischemic, loses oxygen, and eventually over a few hours will die. And we have determined that when you have a plaque in a coronary artery, and I don't want to scare anybody, but we all have plaques everywhere in every vessel. That's nature's way of healing injury to those vessels. You know, the heart beats maybe 1 million times a day, and every time it beats and bends, arteries bend, and they get little minor injuries, just like we do on our arms and hands and so forth. And cholesterol deposits and develops a healing scar or plaque. And most 99.99% of the time, it's natural. Nothing happens. But occasionally, one of these plaques will break down and a clot will form. That's another way of nature's preventing pieces of this from embolizing, but that will block an artery. So when someone has a heart attack, not in the hospital, and we know this, only about half the people that have chest pain and collapse get to a hospital. 50% of the people having that type of event die before they reach care. I mean, it's incredible. I mean, the numbers vary. It may be 40, it may be 30, it may be 60, depending on the city and what your environment is and where you live. And the heart muscle doesn't die immediately in this group of folks. What happens is they develop an irregular heartbeat, a quivering of the heart, like the football player who got hit in the chest. And it's very rare, but it happens. The reason that happens is when the blood flow to the heart muscle is interrupted, so is the electrical system of the heart. If one looks under a microscope, they can actually see electrical-like fibers that travel throughout the heart. When someone needs a pacemaker, it's because one of these things get blocked naturally with age. So what happens is the heart muscle isn't dying, it's just injured, and it creates a very irregular beat that's not functional. Now, one of the things that we're taught is to thump the chest. If someone collapses, thump the chest, because the blow often will convert this back to a regular rhythm. Now, I do have a little story. I put up this cartoon just to tell you that when I was in training in Brooklyn in the 60s, they were just establishing these code teams. In other words, if someone had an arrest in the hospital, the code was called. They use a code. We didn't have beepers, we didn't have cell phones, so they had to announce over a loudspeaker, code blue, room 406, whatever. If you're part of the code team, you drop what you're doing and you rush to that room. Well, we had a code one day. I don't remember exactly what the outcome was, but as we walked out of the room, there was a patient about 3 doors down, frantically waving at us. We need some help. We run over to the room, and there's one of the members of the code team who probably arrived first, lying unconscious across the patient's bed. Well, the patient was asleep. He happened to be a retired boxer. And when my colleague ran in and thumped his chest, he woke up and just knocked him flat. I mean, that true story. I can't make it up. I mean, well, anyway, the modern technique, I mean, we do thump the chest, but you know about all these defibrillators that are scattered in shopping malls and airports and on airplanes and so forth. We had a lot to do with that at the NIH to promote, putting these out there. They're about $2,500, depending on the company, but they have saved lots of lives. And there's one back here. Good, yeah, there it is. Keep it locked up. We don't need it today. And when that happens, when you thump the chest, or more appropriately, can defibrillate someone, you get back to a normal rhythm. That's what it looks like. Well, let's talk some more about heart attacks. 50 years ago, and I think most of us remember what happened 50 years ago. If one had a heart attack, there was not a lot that we were able to do. We put them in the hospital on oxygen. We gave them drugs, whatever was available to relax them. And actually, I might mention that when I was in training in Boston, one of the primary drugs that we used to treat people with heart attack to reduce the anxiety and help them relax was heroin. The hospital had supplies of heroin, which when they used up, of course, became outlawed. Heroin was outlawed many years ago, but they allowed the hospitals to continue to use that. It was a very, very good drug, but of course, very addictive. And we kept our fingers crossed. Bed rest, medication, and fingers crossed. The in-hospital death rate, remember, half the people die before they got to the hospital. But if you get to the hospital, about 1/3 of the people died during that hospitalization. Again, the numbers vary a little bit depending on who's advertising what to come to their hospital and so forth. But 20 to 30% of the people died in the hospital, only because we treated the symptoms. We weren't able to treat the cause, which happens a lot in medicine. You go to the doctor with a rash or whatever, and you treat the symptoms, but you don't treat the cause. Unfortunately, we just don't know enough. Well, again, let me just go back to what is a heart attack and what causes it. Well, this is a picture of a coronary angiogram. Cardiologist, I'm a surgeon. Cardiologists do the diagnostic and now interventional procedures, but they put a catheter in an artery, inject some dye, and this is a normal looking coronary artery. It happens to be the left coronary artery. There are 2 main ones, one on the right, one on the left. We usually don't get those mixed up, but it can happen. When you do an angiogram on someone that's having a heart attack, the artery is blocked completely or partially by clot. And that's what it looks like on clot. It's a filling defect. So the answer, a heart attack is a mechanical event. It's nothing mysterious. It's just a sudden block to a coronary artery. Well, how do you treat a block? We all know that. We use a mechanical procedure to treat and cure a mechanical problem. In 1969, Dr. Rene Favaloro from Argentina was working at the Cleveland Clinic, and he introduced the concept of coronary bypass surgery. It's when you take a vein out of a patient's leg or use another type of conduit and you bypass the block. Now, for some reason, in 1965 to the mid 1970s, this operation was only used for people with chronic angina. In other words, they had chronic but stable blocks, but were very uncomfortable, and to avoid a heart attack. And I remember when I was at the University of Oregon, if someone was having this operation but developed chest pain on the way to the operating room, the operation was canceled. It never made any sense why, but the concept at that time was that it's only useful for chronic disease. Well, again, why not use it for emergencies? Why not use it as a mechanical device to unblock a mechanical obstruction? Here's a picture of a vein going from the aorta to the coronary artery, and it's bypassing a new acute block in a coronary artery or a clot. Very, very reasonable, but not done. Some people in my profession try doing this a day or two afterwards, which is of no use. The heart muscle is dead. You can't resurrect the dead. At least, even as a cardiac surgeon, I couldn't resurrect the dead, but apologize. So we decided, I moved to Des Moines, Iowa in 1974. They did not have a heart surgery program. And so they offered the sun, the moon, and the stars, and we went there. I didn't know where Iowa was. And Susan, who's sitting here, when we got in the car with the U-Haul trailer and pulling the boat and the screaming kids, she said, I'm not going. I'm not going to Iowa. It's cold and it's flat and whatever. But we went there and it worked out quite well. But in late 1974, early 1975, I sat down with the team, the cardiologists and so forth, and said, why don't we treat heart attacks as we should? It's a mechanical obstruction. Let's treat it as an emergency, just as we would treat a gunshot wound or a major trauma from an automobile accident. And it's not that easy to change gears for some of the folks around the world. But what we did was we decided to treat it as an emergency. And what it meant was the referring doctor from a small town in Iowa or even in Des Moines would have to get the patient to the hospital very quickly, usually with a few hours, and do an angiogram and determine which arteries were blocked. And once that happened, we'd go to surgery. And we found out that the death rate, which was around 30% in the hospital 50 years ago, was now around 1 or 2%. It really was. And the 1 or 2% were people who were almost unretrievable because they came in too late. It was a very interesting phenomenon. We had to be notified by the emergency room or the ambulance people that they're bringing in someone with a potential heart attack. Could be middle of the day, middle of the night. We mobilized the team of cardiologists and their people to do the angiogram. We opened up the operating room, had everything open, all the instruments laid out, the heart-lung machine primed. And it was very unusual for us not to proceed because it usually was a heart attack. And so we were very pleased with this result. And we published. I was traveling the world giving talks on how to do this. But the one problem is I didn't sleep for 3 years. It was just unbelievable because it was day and night, day and night. And my wife can, I don't know, smile about it or not smile about it, but well, anyway, fast forward. I learned about a cardiologist, not a surgeon, a cardiologist who was working at the University of Zurich in Switzerland, who was doing something called an angioplasty. I think you're all familiar with this, angioplasty and stents by now. But this was back in the late 70s. And he was using angioplasty for chronic anginal type of disease, which is what heart surgery was being used for, but you skipped the surgery. And there were a lot of skeptics, but he proved how safe it was because he did one on himself. How he did it, I don't know. I never really asked him because we ended up being friends. But I want to just show you a brief video on what angioplasty is.
Angioplasty procedure is also known as percutaneous coronary intervention. The procedure is done on blood vessels called coronary arteries. They supply your heart muscle with oxygen. The goal is to restore blood flow with a substance called plaque that significantly narrow these vessels. A wire mesh tube called a stent may be placed in the treated area. The stent helps keep the coronary artery open. Your doctor will choose the proper size stent, which is compressed over a balloon. The stent will be moved into the artery over the same guide wire. When the balloon is inflated, the stent will expand and lock into place. After the balloon catheter is taken out, the stent will stay in place to hold the artery open.
Okay, good. We got it all down. Going to be able to take it home and, okay. Well, let's see. Okay, battery is running low. My battery is still good, but this battery is running low. Are there any lawyers in the room?
You should be able to.
Okay, thanks, Nick. Well, anyway, I learned about this procedure. I was sleep deprived. I called Dr. Grunzik. I said, Andreas, how about we use your technology for acute heart attacks and we can skip the surgical part? He said, Steve, why don't you come over and we'll talk about it? Well, he was in Zurich, which was just close to Zermatt ski area. So I grabbed a couple of cardiologists and I put them in, we got in an airplane and we said, let's go over there. Cardiologist spent about a week training with Dr. Grunzik, who subsequently had moved to the US after this. And I went skiing. I mean, I didn't have to learn how to do that. I already had my thing, my shtick. And the result was I was able to get back to sleep, which was nice. And it's really the standard of care. The cardiologists take care of most of these issues. The surgeons stand by in case it doesn't work out. We take them to the operating room. But the team, our team, and a couple of other teams showed that emergency intervention for heart attacks really works, and it's the standard of care today. So I'm very proud of that. All right, let's move on to transplants, okay? Interesting slide. Mythology is filled with pictures like this of strange-looking animals, two-headed dogs. Why in the world, from the beginning of written history, did we think about things like this? Man is a man and women or whatever, mankind is a funny animal. Not only was it mythology, but mainstream. 1495, there is a religious painting of Saint Cosmas and Damien performing a leg transplant. And I looked into this because of the difference in color, but it happened to be a Ethiopian individual that had died. and they dug him up and tried to use the leg. Very, very interesting why our minds work that way. Well, remember the two-headed dog? I think it's called Orthrus. Cerberus is a three-headed dog that guards. They didn't worry about three-headed dogs. It was only two for some reason. Well, in 1952, Ukrainian surgeon, Dr. Demikov, did a series of what he called transplant experiments, where he implanted the head of one dog into the head of another. Well, he was studying transplantation, studying rejection. He was a pioneer in heart surgery. It was part of the Soviet Union at the time, but he was Ukrainian. And a lot of the information of what he did not get out until the Soviet Union fell. Very interesting. Now, to get back into reality, many of you, I certainly remember, on December 3rd, 1967, Christian Barnard did the first heart transplant, human heart to human heart. And Christian trained at the University of Minnesota, and I knew Christian. There's a lot of stories we could tell about Christian, but in respect, he's no longer with us. I'll hold it back. Dr. Adrian Kanjowitz, who is a pioneer surgeon, not only in heart transplants, but in artificial hearts in Brooklyn. 3 days after Christian Barnard did his heart transplant, we had been preparing for a heart transplant for a couple of years. We did a heart transplant on a 3-week-old baby who had an irreparable congenital heart disease. And I'm showing this slide only to point out the bassinet. It was in the middle of the night, and the donor arrived, and they said, okay, we need to get a bassinet because we still do this type of surgery. The technology is not there to have a heart-lung machine that you can operate on a tiny baby. So you have to cool the body temperature down to about 16 degrees centigrade. And then you have about an hour in which you can operate, suspended animation. We're getting ready to do the surgery. And I said to the chief, oops, let me back up. I said, we don't have a bassinet. They're all in the animal lab. You know, they're not clean. All the stores are closed. Well, we happen to have a new baby at home. So I ran across to the house staff quarters, and I think my wife was bathing my son at the time. And I said, I need the bassinet. We took it across. So that's my son's claim to fame. Well, here's a picture of our surgery. And there I am, right next to the chief. Unfortunately, the baby did not survive, but that was what happened in the early days of transplantation. We did not understand rejection very well and how to manage it. Well, here's Christian Barnard. About a month after he did his transplant and our transplant, he came to Brooklyn to visit us. And there I am explaining a procedure to Chris. And there's his old professor behind him and some of the staff. But before we started, Chris grabbed me and said, Steve, make this as short as possible. He pulled me over to the window, and there was a limousine parked outside. He said, I'm double dating with Dean Martin, so I need to get out of here as quickly as possible. And I won't say anything more about Chris, but he was a terrific guy. Well, all transplants, and especially heart transplants, we do about 2,500 to 3,000 a year in the US. But only 1 in 10 get a heart. It's really difficult. It's a 0-0 game. Someone has to die for someone else to live. It's really sad. So we work very hard. The community works very hard at increasing organ availability. And we've done some interesting strategies to increase that. One, harvesting and transport. There are all kinds of gadgets that you can hook a heart to, that will flow blood into and oxygen and preserve it for longer than the 6 hours that it's out of the body. That's about the limit. But they're complicated and we haven't come up with something simple. So basically, we just take the donor heart, which is usually in a remote city, put it in a igloo cooler, and carry it to the place where it needs to be. Transplantation is important. And some of you may know this. This blackbird, which was retired, we went to Congress. We actually asked Congress to keep this plane going, keep the pilots trained, and let us use it in the transplant community, because this could, I may have the numbers wrong, but this could fly from Washington to Saigon in 4 hours. So we had a worldwide ability to retrieve organs, not only hearts, kidneys, lungs, whatever else was needed. I don't want to sound too technical or interrupt with anyone's lunch, but that's the way it was. But they turned it down. So we had to develop other strategies. Another strategy was, and I'll show this in a minute, was that if a heart was discovered, but was weak, was not suitable for a direct transplant, but would recover because it was stun related to the arrest or the treatment or whatever, we would sew the heart in piggyback. You may have heard the term piggyback transplant. And this donor heart, which was too weak or not large enough or not strong enough to maintain the circulation alone, we would sew it in piggyback to the natural heart. And over a few days or a few weeks, this heart would get stronger. And very often, this heart would not even be functional. We never took it out because it never caused a problem, but it's a little more technically difficult to do this, as you could see, as opposed to just taking one out and putting one in. But I always had fun with the students and the trainees coming through and showing the EKG and tell me what is this? Well, the D is the donor heart and the R is the recipient heartbeat. So it was kind of a perverse doctor joke that we would use among ourselves. We do have lots of perverse jokes. The media love this. I just grabbed this. There are a million reports like this. Man has two hearts beating. I mean, it's kind of interesting. Well, other strategies to increase the availability of organs and actually eliminate the need for someone else to die is pig to human. We genetically are engineering pigs whose hearts are anatomically identical to human hearts. And I won't say more about that, about the pig and the human. But as you may have read in the paper, some clinical attempts have been made recently, and it seems to be working out. What you do is you knock out the gene in the pig that causes rejection. It's a little more complicated than that. And then you implant the human gene in it so it recognizes it as human. Well, here I am. I had a laboratory at Iowa State, the veterinary school, and I did a series of experiments in the 90s, mid-90s, where I was implanting a pig's heart into a calf. None of it worked. It didn't work at all. We would do this with our team on the weekend. We never did it during a work day. And I guess perversely, the only good thing that ever came out of this was, one, we published that it didn't work, but two, the veterinary students who helped us were able to have a barbecue every weekend. I never participated in it. I just couldn't do it. Interesting piece of history. The first actual heart transplant in a human was performed by Dr. Hardy at the University of Mississippi. And I'll mention the University of Mississippi. We had a dying patient, and this happened in 1964, and he transplanted a chimpanzee's heart into a man. Well, the medical community kind of applauded this and wanted to know how he did this and why he did this and so forth. But again, in Mississippi in 1964, these folks did not like it. It's strange. But he had to go into hiding for almost a year. And I remember when I started the heart transplant program in Iowa, I got written death threats. I have no idea why. It was against the Lord or against this or against that. And they investigated it and so forth, and they stopped. But it's kind of an interesting concept that most of us don't even relate to, something like that. Well, let's see. I think I missed one. There was one video. Anyway, while I'm looking for that video, it's actually an easy operation. So, you can go home. I won't say anything to anybody. And in 19 easy steps, you can transplant a heart. Let me use the computer to show you one last strategy that we engage in. Now, raise your hand if you're an organ donor. Do you have? Okay, well, this is, thank you. And I am as well. But this is related to another strategy. It's actually the Monty Python strategy for increasing organ donations. Well, I stopped eating liver and onions after that. Let's move over to the artificial heart and heart pumps. And I passed those around the room. I hope you all had a chance to play with them. It's an interesting history. Who invented the artificial heart? I mean, we all have read in the papers and seen programs on TV describing the whole process, but I want to share with you the interesting history of this. You recognize this fellow, Charles Lindbergh? Well, his sister-in-law was dying of heart failure. And with all of his resources, he went to this French Nobel laureate, Dr. Alexis Carrel, and said, let's build an artificial heart so I can save my sister-in-law's life. This is a picture of it. I'm not sure how it would hook up. I could not find any more details in the literature. And this is a schematic, and it's really, in those days, done quite well. I don't know if it was ever used. I doubt it. It's more of an external support type pump than something that you would implant. This was a patent, the forerunner of the actual artificial heart, the one I passed around, patent in 1963. And it wasn't patented by a physician. It wasn't patented by an engineer. Guess who it was patented by? It wasn't patented by Jerry Mahoney. It wasn't patented by Mortimer Snerd. It was Paul Winchell. Incredible. I researched it a little bit and understood that Paul Winchell was a pre-med student. He was involved in science. He grew up during the Depression years and his family could not afford to send him to medical school. But he dabbled in science. He became an acupuncturist. He became a hypnotist. And he donated his patent to the University of Utah, patent number and so forth. The University of Utah had a very large, and still does, research institute for artificial organs. It's a separate building. There are different researchers that are experimenting and doing work in all kinds of artificial organs. And this is a picture of the Jarvik heart. This is Rob Jarvik. Some of you may have seen him. Rob was a medical student, never practiced medicine. I encouraged him to take a couple of years of training, so he could not be involved in the physical use of his device. Very, very bright guy, very nice fellow. And he spent a year doing research on the whole spectrum of artificial hearts that the university had been working on for many, many years. And he just happened to be in the right place at the right time, because his work ended up developing this device, which is somewhere in the room. I hope no one is using it. They typically name the particular heart stage after the researcher that was involved in it. So that's Rob's story. Now, you implant it just as you would a normal human tissue heart. You sew it in the same way, except it's pneumatic and the drive lines have to come out through the skin. And it's attached to a large console, which is about the size of a small refrigerator, where you manipulate the dials and so forth and get it all set up, and you could change the level of pumping depending on the activity. And it also comes with a portable power pack. A lot of our devices that we use now all are portable and come out through the skin. But there is a problem. There's about a 40% infection rate from very mild to very severe because it's coming through the skin. And years ago, it's another story, perhaps in the Q&A we could talk about it, but we had atomic batteries that were totally implantable and they were outlawed because some groups felt that the terrorists would capture a bunch of these people and build a bomb, which is not possible. We had nuclear pacemakers and so forth. Actually, the folks at White Sands after World War II, after they did the bomb, they said, what are we going to do next? They said, let's build a nuclear battery. Well, just a quick, there are a lot of stories associated with this implant, but I just have to share one with you. There was a Swedish godfather of crime. Now in Sweden at the time, this was probably in the mid 80s, the definition of death was your heart stopping. The rest of the world is brain death. But for some reason in Sweden, the heart stopped. Well, this godfather of Swedish crime, whatever, had a heart attack and died. They quickly rushed him and put in a Jarvik heart. Well, the courts had to let him go. He had no heart. So he was dead. And he lived for about 6 years or so, going around, drinking his wine, going out to dinners and so forth. And it was just, they changed the definition of death in Sweden to brain death. So now, I've also passed this around. This is a different concept of pump. This is a continuous flow pump. You know, we're all born with a heart that pumps. But as you can see on the two devices that I passed around, the pumping one is a big device, and it's a little difficult, especially in small people or children. The continuous flow pump is based on an Archimedes screw. Dr. Richard Wampler, a friend, a colleague, who was actually my student at Oregon, I said, Rich, what are you going to do one day? He says, I want to invent an artificial heart. Oh, good for you. You know, he was a medical student rotating through our service. And he did. He used the principle of an Archimedes screw, and there was some declassified information about engines that turn satellites in orbit. I'm not sure exactly what that is, but he combined the two and created something called a hemopump. I'm not showing that. But it ran at about 27,000 RPMs a minute. You would think that would emulsify the blood, but it didn't. Dr. DeBakey, who had done a heart transplant on a NASA engineer, redesigned the internal workings of this so that it would not chew up the blood. And so these are continuous flow pumps that are a lot smaller, and they don't replace the entire heart. And only about 2 or 3% of the people actually need a new heart. What they need is a left ventricular assist pump. And this is what this is. So just in comparison, this is a pulsatile pump. That's one of mine that I implanted in a couple of people. It's pulsatile, it's a little complicated. And this is the Jarvik type heart. So most of these pumps now are the ones that are implanted in people, a couple thousand a year. Vice President Cheney had one of these for a couple of years until he had a heart transplant. I want to finish up with this little strange little add-on to this heart transplants and other fun things I did. This was one of the other fun things. Now, when this book came out and the movie in the early mid-'80s, at a monthly research meeting, one of the engineers was talking about this and said, you know, we can build a pump like this. I said, really? He said, yeah, you know, this pumps, I'll explain to you how it works. It's a big word, electrohydrodynamic. Nuclear power plants need to be cooled. And one of the ways you cool nuclear power plants is you pump liquid sodium around as a heat exchanger. Because if you did water, it would boil, and the pump that was pumping the water would burn up. So they use pipes filled with liquid sodium surrounded by large electromagnets, which pulse the liquid sodium around. And this cartoon describes how it works. Now, the little pump that I passed around, the gray thing, which is somewhere, the engineers built, and this is the schematic of it. We never used it because we ran out of money. But blood, which is rich in electrolytes, was pulsed by the electromagnets through a circuit. And this is another picture of it. And this is what it looks like. We tested it. It's about half the size of a shoebox. This is just a not very pretty picture of it encased. And we used a very common standard Mach circulation loop. It's a laboratory loop that you can manipulate to mimic the circulation. You can have a normal circulation, you can create shock, you can do all kinds of different things with it. And you have pacemakers attached and so forth. But you can see what the size of it compared to some of the other things. Well, we published on this. And a few months after we published, a couple of fellows in suits showed up at the office. And they said, how in the world did you guys build this tiny little thing when we've been working for years on this device? Well, they were pretty nice about it. They flew us out to Argonne Laboratories outside of Chicago, which was kind of a strange place. We had to have our passports, and you know how these security things work. And they showed me their electromagnet, which was 76 tons, compared to ours, which was 2 pounds. And unbeknownst to me, and I don't know how many other people knew this, they were collaborating with the Soviets since the mid-1970s on developing this magnetohydrodynamic drive. It was quite interesting. And they asked me, how come we were able to do this with this 2-pound pump? And my response, not being an engineer, was that we weren't static. We had jump started the circulation at 2 liters a minute, and we just pushed it up to 4. They were trying to start from a static position, which didn't work. So it was quite interesting. We never got any follow-up from them. They never gave us any money, which we were hoping that we could use that to continue the experiments. But oops, let me just back up one little bit. The project is still ongoing. In 1992, this thing has a mind of its own. The Japanese built the Yamamoto. It's magnetically driven, and it only went up to 8 knots. But DARPA, our Defense Advanced Research Unit, anyway, is working on it. But thank you for your attention, and I appreciate it. This is actually real water.
Thank you.
I was hoping for something more.
We'll take 5 minutes, then we'll come back for question and answers. 5 minutes.
Oh, I'm gonna get some more coffee. Thank you.
Can I please have my pumps back?